All right, so as we sort of conclude our discussion about motor theories, motor control theories, I want you to sort of reflect on the theories that we've talked about, specifically the 5 current theories and what they may be adding and how they are different and yet in some ways very complementary. So when we ask the question of what's the best theory to use, and I think we need to sort of emphasize and review some of the strengths of each of the theories. So we have motor programs, which is really looking at building a plan, a general plan of action, potentially a plan that can be utilized for many tasks or in many environments. We have the systems theory, which really is emphasizing that biomechanical approach. It talks about subsystems and the task and the environment. And it really emphasizes our need or our ability to harness the momentum and the gravitational forces and the reactive forces and use that to make ourselves very efficient. Neuronal group selection, which really focuses on forming synaptic connections and that building these functional units of connections within our brain, within our system. Dynamic action theory, which again focuses on mechanics and is a great complement to systems theory, thus why systems theory and dynamic action are commonly combined to discuss dynamic systems theory. But again, dynamic action focuses on the mechanism and the stability of the pattern. So how stable is the pattern, and what are the things that sort of facilitate a change, the control parameter and the order parameter. What are signs that that pattern is becoming unstable and then potentially changing to a new pattern? And then the last theory, ecological theory, that we looked at that really emphasizes the perception and action relationship and how that is built. And we'll talk about how it's built when we talk about motor learning and how it helps us to adapt to an environment that is many times very unpredictable and can change on a dime. All right, so again, reviewing these and sort of getting comfortable with it, that's what we're going to work on all semester. But let's go back and look at maybe a little bit where we came from, and then we're going to talk about a task-oriented approach. So now that we understand not only the current 5 theories, but maybe the history of where we came from when we talked about reflexive and hierarchical theory, we can sort of review where, as physical therapists, we've come from in our intervention techniques. So how are our intervention techniques related to these theories? So in the 1940s, we were really focused on muscle re-education approach, and that was something that was really credited to Sister Kenny, who was working with children post-polio and really looking at re-educating muscle. So that's where we started in this muscle re-education approach. But then as we moved into the 50s, 60s, and even into the 70s, many of the intervention techniques were really focused on that reflexive hierarchical theory. So we talk about neurodevelopmental treatment with the Bow baths, Rude when she talked about sensory changes, Brunstrom's approach where she looks at changes in motor output based on recovery and higher centers taking over for lower centers. The proprioceptive neuromuscular facilitation of Cabot and Knott, very much based on this reflexive hierarchical theory, building these patterns, enforcing patterns of behavior that are controlled by higher centers versus lower centers, and then sensory integration with Jean Ayres. And again, higher centers taking over for lower centers. So from our past, we really were well ingrained with the theories of the time, the reflexive and hierarchical theories. That doesn't mean that we're going to throw out these interventions. It just means we're going to examine them with a different take on them, using different theories. So really quickly, as we review some of the assumptions from these older theories, normal movement is a result of a chain of reflexes that's hierarchically organized in the central nervous system. abnormal movement is a result of disruption of that normal reflexive mechanism. That lesions in the central nervous system are going to cause abnormal movement and release higher centers from control over lower centers. And the two big assumptions that we see, particularly with NDT, is that once an abnormal pattern is inhibited and we facilitate normal movement, function will return. And 2, repetition of normal movement will transfer to functional tasks. So if we just rehearse over and over again the synergy, that it will somehow magically reappear in the functional task. So clinical applications for these two theories, as they're combined, we would identify the presence or absence of reflexes, like we've already talked about. And then our intervention goal is to regain normal patterns of movement, which will lead to normal function. Which again, many of us who were using some of these techniques, that was really the trick, is getting patterns that we would rehearse in the clinic to then be utilized during normal function. All right, so as we move forward in pediatric physical therapy in general, how do we approach the patient in a different way, and in a way that sort of takes account of these new theories? So we're going to talk about the task-oriented approach next. So now the current approach, the task-oriented approach, which actually I used for all the modern therapies. When I talked about examination, I always started examination with examining tasks, particularly tasks that are challenging for our patients. So we're always directed to specific tasks that our patient's having difficulty with, and they need to be tasks that the patient is using currently and is also motivated to improve. So with the task-oriented approach, we will always examine and evaluate tasks and taking into account the system while it's performing the task, the specific requirements of that task. What do I need to do for that task to be successful, and what's the environment that I usually function in? Because those three, the system, the task, and the environment, are intimately connected, and that they result in a very specific motor behavior output. And so if you're not looking at a specific task and a specific environment, the motor output required may be quite different. So then when you ask your patient to go back to their typical environment and function, if the task and the environment aren't the same, it may be very difficult to carry over what you did in the clinic to what they need to do in their own environment. So intervention, we work on specific tasks that are driven by clients in a specific environment that the task would typically occur in, or occur in their natural environment. And we're going to emphasize any systems which may be impaired or that are the limiting factors for that task being functional in their natural environment. The other thing is movement adaptation is appropriate if you want your clients to function appropriately. So we're not here to insist that a client moves in a very specific way. Our goal is always on function, and there are times if a system is not going to be recovering, that we may modify or adapt movement so that they can be functional. And keeping them as functional as possible is always the goal, because we want to maintain physical activity and physical health. All right, so the next slide contains some references. Like I said earlier in one of the lectures, I'm hoping that the reps will get together and we get a chance to set up a time that we go over any questions that you may have. I'm open to reviewing your application table, and maybe we can discuss some ideas you had. I would not be a bit surprised if you came up with some different ideas or emphasized things slightly differently, and I'd love to hear about these. All right, so this is the end of motor control theories. You're going to review these in lecture and lab for the rest of the semester, so it's a great time to dig in and start the semester off right and really pull these theories and learn these theories well and work on applying them to the clinic. It will be really helpful for you for the rest of the semester. All right, guys, I hope you're having a good week. I can't wait to come back and meet you all, see you in person. And I will see you I'll be back the week of the May 15th is actually when I'm returning. All right, talk to you guys soon. Bye.